chapter is this? Okay, you got that's fine. So it's chapter 41. In the new book, what chapter is this? Anybody know? It is 38. You are correct. It is 38. Okay, so with different books it is 41 and it is chapter 38 is where we'll be today. Okay, and we're talking about the nervous system. And people getting nervous, right? Well, I've got one up on you. This is the first time I've lectured for a long time. And I've not ever lectured in nursing school itself. I've lectured in several other places. So this is probably the perfect place for me to start, okay? The nerves are kind of in charge of a lot of things, right? People get really upset and I can't handle this, right? Their nerves, their stress. What I want to think about is there are many things that the nervous system affects you guys already know about. You've already seen it. You've seen clinical pictures with your family members. And it will affect your family in one way or another, regardless. Some way, somehow. Maybe not right now, but it will eventually. So it's good information to have and be ready for. Okay, we've got, starting off with the assessment of the nervous system. You've got your parts. Have you seen this before? Everybody seen this before? Okay. All right, things about this chapter that we'll be talking about are cognition. So we've got to do the thinking portion, right? And that affects a lot of the neuro diseases. It's the cognition, the thinking portion from the brain. Mobility. So the movement of our people. Are they falling? Are they, what is their gait like? Different things like that. So movement's very important. And then sensory perception. So what is that? Are we aware of our surroundings? So somebody with Alzheimer's or Parkinson's, do they always know what's going on? Or somebody that's just had a seizure, do they know what's going on? They don't always. I mean, when we think of our patients and their safety, we have a fire at the hospital. What about the patients that can't get up and move themselves? Well, maybe they don't even know at home that their feet are that cold or near a fire. If they don't have the sensory, they're not going to even know they're getting burnt. There's a lot of different things, so that's why we have to make sure of the sensory perception. The interrelated concept for this chapter is perfusion. Because we're talking about nerves, we're talking about the brain. If the brain doesn't have enough blood, it's going to cause all kinds of problems. So we have to have the necessary blood supply. All right, our A&P review. You guys have all had anatomy and physiology, right? All right. So as we look at things here, the division of the nervous system, for control of cognition, mobility, and sensory perception, the three things we have to have. We have the central nervous system. What's that consist of? The central nervous system.
Brain and spinal cord.
Brain and spinal cord. Beautiful. And what about the peripheral nervous system?
The nerves extended.
Spinal, and then your spine and cranial nerves. Spinal and cranial nerves. Right? Okay. And then our neurons go down and we'll have motory and sensory. The motor is our efferent and our sensory is our afferent. So it goes all the way down and out. Okay, so some's controlling, the motor's controlling, and what's with the sensory, the afferent? It's sensing what we need to do. Okay? All right. If you have your books with you, page 826 is where we are, as we talk about the major parts of the brain. Okay? And that forebrain has to have, all of it has to have perfusion, but especially we have to have perfusion for that brain. The thalamus in the brain here we have is our central switchboard, so it controls what we're doing. The hypothalamus, does anybody know what that is in control of? Temperature, right. We can tell if there's a big problem with that. we're watching their temperature. And we have to remember that's one of the basic vital signs. A lot of times we get stuck on our vital signs only being blood pressure and pulse. But we do have to remember temperature is there. Our epithalamus, that one is our emotions. Have you ever seen a stroke patient just cry, and we can't get them to do any, we're like, what has happened? Maybe that's where their brain bleed or their stroke occurred. Okay, our cerebrum is our largest part, gives us our intelligence, our creativity, and our memory. Okay? And it is divided into two hemispheres by the cerebral cortex. And we need that for our higher function of the brain. Now, we have one that you should know the function of. What about the cerebellum? What does that do for us? I want you to go ahead, I'm sorry. To what does it give the information to? Joints, muscles. Okay, and it does this. What does it help us do? It helps us keep our balance. Cerebellum balance. Keep that in mind. Cerebellum balance. If you have a person that has a gait issue or they keep falling or losing their balance, we need to be thinking the cerebellum. Cerebellum is balance. Okay, the spinal cord. What do we have to have in that to protect it? We have to have the cerebral spinal fluid, right? We have to have the fluid to keep those nerves innervated. All right. Talking about our spinal nerves. Anybody know how many we have? 31. Good. And what's the breakdown? Where do we start? At the top. Which ones are these? Cervical, how many? 8. Yay, 8. And then our next ones on the back side, but what is this? Thoracic. And how many of those do you have? 12. Awesome. What's next? And we have a lot of surgeries in this area, right? The lumbar. Okay. And how many of those? 5. How many of this next one, the sacral? 5. You got it. And what's our bottom one? Coccyx. You don't want to break your tailbone. I promise it is not fun, especially if you're roller skating with your children and you end up on it. It's sore for a couple years, minimum. Unfortunately, I represent that one. So, okay. So we've done our spinal. Cranial nerves. How many of those do we have? 12. There is a beautiful table in our books on page 829 that talks about all of them. I don't want you to have to memorize it, but I want you to be aware of it. You need to be aware of it because those things will come up. And the reason why I asked you about how many vertebrae we have, that different type of thing, when you go to read your patient histories, you're going to see this and you're going to go, oh, where is that? What is that? What do I need to remember about that? And that's where this all connects and puts together. Okay? All right. Let's see here. When we talk about at the bottom of page 828, this is information you want to know for certain. The posterior branch. Okay, we're talking about our posterior branch, which is our sensory perception. Okay? And that's afferent. Then the anterior branch, it takes our motors to the muscle, and that's the efferent pathway. And that gives us our mobility. Think of motor to the muscles as our mobility, the efferent pathway. Okay? You can almost aim that, AME. Anterior, motor, and efferent. Okay? The other one is PSA, posterior, sensory, and afferent. Okay. What's our autonomic nervous system? We're going to get right there. That is our sympathetic and our parasympathetic, right? Our conscious control. Am I going too fast through this fun stuff? Not too fast? Okay. All right. Our sympathetic nervous system. Which one is this? Fight or flight. What's going to happen to our heart rate? What's going to happen to our respirations? When does this occur? When something's very urgent, stressful, emergencies. Okay. And this occurs from the spinal cord T1 through L2 or L3. Okay, the parasympathetic nervous system is going to be from our sacral area of the spinal cord, S2 to S4, and some cranial nerves. Now, we said the sympathetic does what? Increases everything. What does the parasympathetic do? It slows our body functions, except in two areas, digestion and reproduction. So they named it, I'd never heard of this in the book, the feed and breed. I had never heard of that. Have you heard of that before? I thought that might be new material in here. Okay, neurologic changes associated with aging. They affect our mobility, so our bones, our nerves, our muscles, our joints. Okay? The sensory perception, that's our pupils. What do they do with age? They constrict, which brings in less light, which means it's harder to see. So you see a lot of the elderly with sight problems. And the pupils will adapt slower. What about hearing? There could be damage to the hearing, right, over time. What about their touch and sensitivity? It becomes lost, like their feet, they will shuffle more, or they're not sensitive if they're diabetic. They've lost that sensation, which is going to increase our falls and problems. So we really always have to watch the functional status. We have to be aware of cognition changes. Cognition should not change with age. Okay? Intelligence does not change with age. But drug interactions or toxicity or hypoxia, they're not getting enough oxygen. Problems with drugs, drug interactions. And when I want to say intelligence does not change with aging, I'm going to use my mom as an example. You might hear of her a lot. Love my mom. She's just turned 89.
Wow.
She was a retired nurse practitioner, okay, in infection control. So believe you me, she has lots of interest in COVID and all the things going on. And she's surprised at all the neural things that happen with COVID. Can anybody give me anything they know that's happened to a COVID patient, our world right now, that affects the neural system? Yes? Smell and taste, that all affect. Yep. Nerve, absolutely. Anything else with COVID? Has anybody seen anything nerve related to that? It's very important. I have a family member, my son's father-in-law ended up with Guillain-Barré, which we'll talk about post-COVID. I've admitted patients to the hospital with the trigeminal neuralgia. So there's a component from COVID that, we're still learning about, but it does affect the nervous system. Okay, so my mom is really interested in, always keeps up on things. What she does every day to make sure she doesn't lose her mind is she does a crossword puzzle, and she thinks she gets through her crossword puzzle, she's going to get through her day. One of the other things she does, she plays the piano daily. So that's left brain, right, and she's functioning, and foot, and keeps it going. I mean, I don't know too many 89-year-olds that still get paid to play music. She played a funeral just a couple weeks ago and got paid $100. She goes, I said, there you go, Mom. The prices need to increase a little bit. But so she did not lose her intelligence or her intellect with her age. So I want to make sure you understand that part. All right. Now this next one really affects you guys because you're nice and young, and when you're young you don't have as many limitations. You're not as scared, right? So you're able to do those risky behaviors. And we want to avoid those and practice some healthy lifestyles. What kind of risky behaviors do younger people tend to do? It doesn't mean older people can't. They may go skydiving or something because they're like, whatever, that's on my bucket list. My life's almost over.
Really?
Huh? Some of the elder, I've seen.
Is that on your bucket list?
No, it's not on my bucket list.
Oh,
I've
okay.
seen,
I thought
not
you
skydiving,
personalized
not my bucket list. But I have seen older patients. Well, there was a movie too, right? You guys recall that?
Isn't it cool?
The bucket list, yeah. And he wanted to go skydiving, right? Okay, so a lot of youngsters, and I still am guilty of this, like to speed in cars, right? Take risks, do different things, especially, what about our military? Folks that are in the military, they're pretty young. Sometimes they don't have a choice on the risk that they have to take. But what happens to these people? They get hurt. We can have that traumatic brain injury. We can have, long-term effects, car accidents, lots of different things. Or you have the ones that have the spinal cord injuries and they're paralyzed, different things like that. So the things we can do as a healthy lifestyle is definitely enough sleep. This is something I fail at. I know it's hard when you're in nursing school to get enough sleep. It really is, but it is important. So sometimes, rather than going through your notes one more time, you're better off getting a decent night's sleep, get up and look at them the next morning for a test, different things like that. But get enough sleep if possible. Proper nutrition is also hard when you're in nursing school, right? But it does take effect. I mean, if you think of even just getting enough sleep, think of car accidents. Do they usually happen when people are just normal, awake, and alert? Or is there a component where you were tired, where you hadn't had enough sleep? For me, there was. That does play in there big time. Okay. Assessment. Let's see. Wait a minute. Okay. With the patient history, sometimes this is hard to get, depending on their language. In your language, are you going to communicate? Are they able to hear? Are they able to answer your questions? One that we forget a lot of times, do they actually read or write? It's very difficult to teach a patient that doesn't read if we don't have the right tools in our tool belt to do that. Okay, physical assessment. We're going to do a complete physical assessment. You guys are used to that, but the neuro assessment, we're going to check their mental status. So like memory loss, confusion, the cranial nerves. Right now you're not going to be tested on the cranial nerves, but there is a nice way to get through those. And it's mostly pain related. You're going to be looking like a person with trigeminal neuralgia. Where do we think that is? Cranial nerve number 5. Okay? And anybody know anything about trigeminal neuralgia? Extremely painful, and it's also called the suicide disease. Because the pain is so severe, those people are ready to commit suicide because they cannot get rid of the pain. Nerve pain is some of the worst. Okay. Motor function. That's our push and pulling, when you'll have your hand grips, that type of thing. Okay, sensory. I mentioned Guillain-Barré before. This is where sensory starts low at their feet for Guillain-Barré, and it comes up the legs until it causes paralysis. Now, it's bad enough that they can't walk, right? But if this sensory is coming all the way up, what if it gets up here? What happens? They can no longer breathe on their own, and they have to be put on a ventilator because it comes all the way up. And eventually, sometimes it gets better, and it'll go back down. But not always. Some of those people end up on a vent the rest of their life. Also with sensory, that's where we can poke with the pen on this side or the dull side, sharp side. Okay, for patients. Our cerebellar function, what did I say that we want for the cerebellum? What is it? Balance. Balance and coordination. This one we can do like the heel. Let's get everybody see. If the patient's lying in bed and we will ask them heel, then they have to go down their shin. Then they have to do the other one. Everybody put your hands out. And I want you to take your pointer finger, bring it to your nose, and back, and the other one to your nose, to your back. Close your eyes. Do your right one. Close your eyes. Do your left one. That is pretty good. What's that?
Please stop.
That would work, wouldn't it?
No, they do that if they're checking.
Yeah, they do. They do it as a check as well. Absolutely. I guess I haven't experienced that one. But another one that you could do is have their hands on their thighs. Flip back and forth. I mean, how quick can you do that? Like she said, probably if you're intoxicated, not too well. But that's checking our functions. Okay, this next one. Has anybody seen the posturing of a neural patient? Anybody seen anybody after seizures? Seizures are very scary, right? Very, very scary. So does anybody know what posturing this first one is? This is something you will need to know. Because when a physician comes to you after the seizures happen, you have to describe it. You have to tell him, and he's going to say, was it decorticate or was it De-Cerebrate posturing? And that's going to be something he wants to know. So make sure you write this down. This first one is decorticate. How do I know it's decorticate? You guys are all athletic. You're all in shape, and what are you working on? You're working on your core. Decorticate, look, bringing it right into the core. Okay? Decorticate. Okay? What does decorticate mean? That means we've got some damage. We've got some brain damage. They may be in a coma or paralyzed. And they will also be people that will have seizures. Decorticate. So that we've got brain damage, coma, paralysis, and seizures. Okay? De-Cerebrate. Okay, this one, so they're not going into the core of the arms, they're going out, right? This is bad news. Going out with those arms, think of it, the patient's going out. This is the most serious, and this is a brain injury. It's not just damaged, it's injured. We won't be able to possibly won't be able to fix that. Okay? Let's see, everybody. Let's see your decorticate posturing. Okay? We also have a flex of the legs. I'll go ahead and do those so you get it. Decorticate, and let's do our De-Cerebrate. The legs still do the same. But they're going out, right? Not good news. All right, Glasco Coma Scale. This sometimes becomes quite a pain for nurses charting. And it's easy to get in a rut and give it a certain number as you score the patient to the eye opening. Spontaneous to sound to pain, never. And motor responses. Oh, they obey commands, But the thing is, this tells a big story. And so we don't want to get in a rut when you're charting. And this is in your daily charting, especially on a neural floor. Or if you've had a patient that has had a stroke or a patient that's had seizures. All right. This is just our standard rapid neurological assessment. You have to do it upon admission for every patient. And if there's any changes, you'll be doing this. So possibly in the hospital, you may have to call a code stroke. Different things because we have these neural changes. What's the perfect score on this? 15. We want a high score. All right. And a coma is at a score of? 8. Okay, let's talk about brain injuries. If it's very severe, it's 3 to 8. If it's moderate, anybody know? 9 to 12. And if it's mild, it's 13 to 15. Okay, so we want to know if they'll respond to your voice, or to light touch. If they're not responding to that, we call it obnoxious. It is pretty obnoxious. Painful stimuli. They appear to be unconscious, and what do we have to do? You guys ever heard of a sternal rub? All right. Have you done it to yourself? Try it. Just enough to get your knuckles. And try that. Think that'll wake you up, especially if somebody's doing it hard? Maybe. Yeah, you gotta do it hard enough. I don't want you to get too bruised or sore, but if you were out, okay? All right. Questions on the Glasgow Coma score?
Could you repeat the grade
Scale.
again? You said severe,
Severe
breakdown.
is 3 to 8 for a brain injury. Moderate is 9 to 12. And mild is 13 to 15. Okay? And you'll see this all the time is a GCS, will be that abbreviation you will see. All right. Next one's our psychosocial assessment. Okay? The thing is, the response from the patient may vary depending on whether their condition is acute or chronic. We're going to see differences in the patient, like, so say, Bell's palsy. Is anybody familiar with Bell's palsy? Okay, so you've seen it. Can you tell me anything about it?
Basically, it's when, like, one half of your face is, like, paralyzed.
Uh-huh.
And so, like, it's hard for them to, like, if they have, like, solid food, it's hard for them to chew because then they can choke or...
Mm-hmm. They can't usually, so it'd be like this side of my face is, so I can smile on this side you can't at all, and it's all paralyzed, and this eye is open. This one will blink, but that one will just stay open, and it won't move. It's in a fixed state, okay? It's like, okay, but is it forever? Not typically. So that's one that is going to be it's an acute phase, and usually for the first 2 weeks their symptoms are worse, and then it'll go away 4 to 6 weeks typically. That one comes on by stress, different things. That would be Bell's palsy versus our chronic. Can you give me an example of a chronic neural condition? I've mentioned it several times.
No, that's cute.
I didn't hear you, I'm sorry.
Nothing.
Okay. Not a nothing, that's not what it's called. How about a stroke? Okay, so that's a chronic condition typically. Okay, and the biggest part is this depression screening tool. Stroke patients typically have depression. I want to say almost up to 90%, especially, even after they've gone through rehab and that. And the thing with that is there's a test called the PSQ that they will take. And if their score is high enough, then you have to notify the physician. So there's a lot of different tests. There's a lot of different things that we have to be aware and cognizant of as nurses, because we're going to have to go ahead and initiate these. You know, that doctor's going to want to know how their mood is. Are they responding to people? Because he comes in at 4 a.m. and just wakes them up and startles them, right? So does he get a true assessment of what's happened all day long or how they were throughout the night? He just sees them. That doctor comes in. Usually 5 minutes is all they're in the room with the patient. They are depending on the nurse's notes. They need us to paint the picture for them what's really happening with the patient. We have different communications with the doctor, plus our charting, so it's very imperative that we give them the right information. Another example of the acute or the chronic would be a delirium. So they're only in it, the state of confusion for a moment. But dementia doesn't typically get better, right? That would be one that would be chronic. All right, what kind of things are we going to use to take care of these people and figure out what's going on with them? All right, any idea? Do these look familiar to anybody? Okay, our labs. If we have a patient with an elevated lactic acid, that could be a problem. There's a lot of our lab work that'll come out. So the imaging assessment. So we've got this huge radiology department that is great and has all these things. I've not seen that in my life, but it does have. Okay, plain x-rays. Well, tell us a portion, of course, but plain x-rays usually tell us about bones. Cerebral angiography. Excuse me. All right. What do we know about that one? Anybody? So they're going to go in and they will use a contrast, and then they will be able to see the cerebral arteries. This one you've heard a lot of, right? The CT scan, computed tomography. That is used, it's very quick and easily accessible. That's typically our first one for a stroke patient that comes through the door. We have a time they have to come through the door as a stroke patient from EMS, or if they come to our door, and we want to have them to CT in less than 10 minutes. And we will know, we are being timed on strokes. That's a big thing. And we will talk about that at clinical, okay, as far as one of our pre and post conferences. We'll be talking about stroke like yesterday was diabetes. All right, your MRI. What about our MRI patients? What's that going to do? It's going to help us with the brain and spinal cord. And the one thing you, as a nurse, so they're going to go see why they're having all these headaches, or they're going to, look for different things. But as a nurse, what do you have to do? You have to have a checkoff list before they can go to MRI. What do we have on that checkoff list? What's the big, big no-no? No metal. Why? That magnet, it's horribly strong. Have you ever seen pictures of their name badge has the little clip and that metal goes, if you have the wrong IV pump, it'll go directly to that magnet. If you get close enough with an oxygen tank, it's extremely dangerous. People have been killed because we didn't take care of the metal. So that's why as the nurse, you will have to do that portion of the assessment for the patient. All right, but it does give beautiful pictures. Okay, the PET scan, positron emission tomography. What is this one used for? Any idea? It helps us with assessing the drug metabolism and metabolism alterations in the blood flow. So if there's blood flow problems.
They've used that for people with schizophrenia.
Have they?
To watch.
Okay.
To watch hallucinations as they're happening, to watch the blood flow in the different parts of the brain.
Oh, good.
Impressive.
It is impressive. Okay, I have not seen a SPECT, the single photon emission CT. Have you seen one of those before?
I haven't seen them, but I know that they have used those inside too.
They use it because it can detect a coma for the patient that's in a coma in a vegetative state. All right, this last one, this is the one I have not seen, the Meg Test. Anybody want to say that word? So I don't have to? Yeah. It's almost like supercalifragilisticexpialidocious. Only I can say that one. Okay, this one is not seen very often because it is extremely expensive, and a lot of people don't have the equipment to do it. Okay, but it is the most accurate of all radiologic tests. Okay, an EMG, electromyography. This is used to identify nerve and muscle disorders as well as spinal cord disease. Has anybody had one of these? When you're getting ready to teach your patient, I had some arm issues after my head injury, and so they apply these electrodes to you, okay? And then you're supposed to be there and relaxed, and all of a sudden, your hand moves, or this finger, or the whole thing will jerk. And the thing to keep in mind for your patient, it is not comfortable. Because if I'm doing it, I'm expecting it. My mind is telling me, my brain's telling me what to do. When they're doing this test, your brain is not telling you what to do. And when those muscles, and you have that movement in your joints, it's uncomfortable.
I thought it was painful putting those in.
Besides the little needles, putting them in?
Yeah,
that's...
Putting the little needles in.
Yes, but I think I prepared my mind for that. But the fact
that...
that...
had done, and he was talking about, you could never
But
do it again.
you would never do it again because the needles were...
Yeah.
My thing was, you were moving and your brain wasn't prepared for it, and that hurt. So you do kind of want to be ready for that for your patient. See, I didn't know how much I was going to love neuro until I got in here and went, I've done this. I'm kind of an example of this. I haven't had this one, though, an EEG. And a lot of times they will ask for this. It's hard to get these done at specific hospitals. It's hard to get them done in the middle of the night because you don't have the staff. is this takes a special technician to do this. So that's going to do the electrical activity in the brain, okay? The different hemispheres. And when they do that, so have you ever seen the pictures of this? Have you ever seen one? Okay, you want to explain it?
They
Caitlin?
have like these, almost like, you know how we put leaves like on our chest, they have leaves like on our head, and they put like a netting over it.
To hold it?
Yeah, they just do it for people who are, like in a coma.
Mm-hmm. And we have to determine brain death
Yeah.
or not?
When they do ECT for persistent vegetative depression, major depression, then the psychiatrist is, with the ECT, he's having an EEG ongoing so he can see that there's a seizure going on.
Yeah, and in the hospital, when they do these, they always have a screen and like a
Right.
camera
So that they can watch.
to monitor the patient in real time.
Yeah, exactly. What if we have some slow waves? Is that good? No, that would be our abnormal. We don't want slow waves with this. We want some good waves and quick. What about the nursing care for this patient? So you just had your patient that had this, and they took all these off. What do you have left on their head? All kinds of that pasty glue. That's disgusting. I wouldn't want to lay there with that. So what can we do if that patient is bedbound? We can't get them up to a shower and help them wash their hair. Shower caps, shampoo caps, the ones where you do in bed. Yes. So you got to think about, so they're going for these tests, but what is your role? What are you going to do to help take care of them, to make them feel as normal as possible again? Okay. Always have our nursing interventions. All right. This one is evoked potentials. So something has caused a response. To measure our electrical signals to the brain generated by hearing, touch, and sight. So if we think about this, our auditory ones, can anybody give me an example? Somebody with a hearing, what kind of things? Does anybody ever get a headache from loud music? Not really? You're just, or we have people that have listened to loud music and they've lost hearing function. We have people, military, police, that have been, or construction workers, their work has caused problems. You may have a high frequency hearing loss. I was all over my daughter when she was in drumline. She had to do drumline. I'm like, no, you're a string player. You need your hearing. She's like, oh, it's cool, Mom. I can't, I'm not going to wear earplugs. I'm like, you're going to wear earplugs or you're not playing. Oh, no. So she did finally start wearing earplugs. And here she was tuning her viola. She had trouble tuning her viola. And she could tell the difference even when in high school. And I'm like, look, you better wear those earplugs because drumline, you may be center snare. That is not your scholarship. Viola will be. And so now she's like, oh, I'm so sorry, Mom. But it's taken years. So, yeah, we have to be careful with what you're doing and what deficits we can occur just by all the extra noise. They also may, besides that high frequency hearing loss, they also may have a clicking or other noise, okay, that they hear on a regular basis. There's certain tones my husband cannot handle. As an example, like the screeching on a chalkboard, I don't like it, but it doesn't kill me. I don't know if it kills you, but there's certain high pitches. When my daughter's playing on viola, he's like, ooh. I'm like, okay, it'll be all right. Okay. What is the somatosensory? Oh, I forgot visual, sorry. So we have to see if they have any eyesight problems, like your teacher, or even visual fields that they can't see over here. Okay? But the bottom one's somatosensory. What was that one? That's a little shock to the peripheral nerves, especially like in MS. Okay, they'll feel certain pains and shocks. All right, lumbar puncture. Has anybody ever seen one of these? Has anybody ever had one of these? They are not fun. I don't even like to do them as a nurse. I think I have, this is the one thing that I got real queasy. I can handle lots of blood, GI bleeds, all kinds of things. But this is the one thing, I don't know, maybe it's just messing with the spine. But I remember as a new nurse, I had to do a lumbar puncture at the bedside with the physician. Whew, I got queasy. but I also probably didn't eat real well that morning. So you always have to make sure before going to the OR and before your shifts, even if you're not in the OR, that you at least have some food in your stomach. Okay, what do we have to do with this patient? This is a nursing function you will need to know. Physician comes to the bedside. Eric, he's coming in. He says, I'm going to do a lumbar puncture on the patient. It's going to be in the patient's room. Who's his assist? You, the nurse. You get to be the person assisting him. Neurosurgeons are a different breed than orthopedic surgeons. Orthopedic surgeons, you know,
Those are
they're
carpenters
right. They're based up.
on the body, carpenters on the body.
But the neurosurgeons, I've had one that about drove me nuts. He would not talk to you. His nurse talked for him. And I kid you not, one day we were trying to get some orders, and he's sitting at the table, and he's playing with McDonald's toys. McDonald's toys. And this is a brain surgeon. I said that to my mom. How are you supposed to deal with it? She goes, everybody has different gifts. You know, you can't do brain surgery, but he can. He can function and do, but so, because of his other deficits, you know, and being so autistic, he had a nurse come and be his communicator for him. So these neurologists, they are sharp, but their personalities can be really, really different. And with each one, it's different. So when you're being the bedside nurse, and you have to be ready for the lumbar puncture, you kind of need to know a little bit about them. You kind of need to know, do they want this certain tray or do they need this extra instrument? So when that physician calls you, you're like, okay, I'll have this and this. Is there any other equipment you would like? And that's a good thing to ask all physicians. Urologists are
Do
crazy.
you have files
Hmm?
where do you have nursing files where you kind of document their preferences?
Not that I'm aware of, but your charge nurse usually does, or
I
your
was gonna
coworkers.
say, why would you reinvent the wheel? You just,
Mhm.
when you know he's
I'm
coming
not-
back and coming back, you figure it out.
Mhm. So it's usually the nurses that have been there that are the biggest help. Okay? And unfortunately, at St. Mary's, where I've worked so long, we don't even have a neurologist right now. We have no neurologist on staff. Everything has to be done by the virtual medicine. So the ER doctors have to do this. So what you're going to do is you're going to have your patient on the side, okay? And what are they? They're coiled up into a C with their knees up, okay? And why are we doing that? We're doing that to open up this space as much as we can between the vertebrae. Where do they go? Of course, we're going to clean the area and make sure everything's ready. They go between L4 and L5. Then we go in, as you can see, in between, boom, and then what are they trying to get? Cerebral spinal fluid. And once they tap in, it'll leak out. And your responsibility is there's these little tiny cups. And you got to catch, help them and be ready, and you're going to catch that cerebral spinal fluid. What is that cerebral spinal fluid going to tell us?
There's blood in it?
I'm sorry,
If it's like blood in it?
if there's blood in it, that's bad news. If there's blood in it, we want it to be clear. But yes, it may have blood in it, and it can also, we were going to send all these, we're going to send at least 4 samples to the lab. And then it'll tell us the bacteria, or if there's any other signs of infection, it'll tell us a lot about the cerebral spinal fluid. Okay, what happens after this? So you've got your patient, they're in pain. He first injects some lidocaine to try to make it easier, but you know, if you've ever had lidocaine, what is it? It stings, it hurts when they're putting that first one in. And then he does this, and he's poking and prodding, and it's a lot of pressure for them because the spine is not used to having anything in there. So there's a lot of pressure going in. The same thing is very similar to having a baby, having an epidural. They'll say you're going to feel a lot of pressure. Because what are you doing? You're going right into that spine, into the epidural space. So we've got this done. We've got the sample sent to the lab. You've got this patient to take care of. What are you going to do for him? They may stay on their side for a while. They may not get up and move a bunch quickly. Because if we do, that hole in the spinal fluid, it can cause, if there's a leak afterwards, it usually seals off, but if it has a leak, what does that cause? A spinal headache. Now, those are horrible. That I promise. I had to be hospitalized for a spinal headache. I had a myelogram that went bad. My daughter was 7 months old, and my boys were 5 and 6. And I was flat on my back in the hospital. If I sat up, I vomited. I couldn't handle any light, the photophobia. Your head hurts so bad, okay? And so how did we get this healed up? They gave me a morphine drip for the pain and a caffeine drip. Crazy, huh? Caffeine. And when I did get released to go home, they said drink Mountain Dew. I kept drinking Mountain Dew. Like crazy. They did a blood patch. So they take your blood and they go ahead and they inject it where you had the hole, okay? Because the hole where it's leaking is what's causing that horrible headache. So with the blood patch, it should seal it. Except for, unfortunately, you can't do that up till 24 to 48 hours. You have to deal with the headache first. And if the blood patch doesn't work, you got to wait another 2 weeks to have an additional blood patch. So I was on bed rest because there was not a doggone thing I could do but flat on my back, you know. Couldn't take care of my kids. Just drank Mountain Dew and tried to keep the pain under control in a dark room with your head covered with pressure. Not very fun. So make sure, what are we going to do for this patient? We're make sure we have pain control. We're going to watch their movement, make sure there's nothing leaking, and make sure they don't have horrible headaches. If they do, you're going to be calling the physician. All right. Another study that we can do is the transcranial Doppler ultrasound. The good thing about this one is it's non-invasive, okay? So we can see the arteries, we can see if there's narrowing, that type of thing, and where the problems would be. Okay? Questions so far? All right, let's do, we let them out at 11, or do we let them out? I don't want to get in trouble for letting them go early. Should I go ahead? What time do you let them go?
We have class from,
Till
they have an
11?
hour for lunch.
Hour for lunch.
11 to 12.
Okay, let's get a couple questions in here. All right, emergency department nurse has a 78-year-old patient whose daughter reports a decrease in cognition. Which nursing statement directed to the patient helps the nurse to assess cognition? Cognition, so we're thinking, their thinking process, okay? A, tell me what this fable means to you. B, please count backward from 100 by sevens. C, tell me how you were transported to the hospital today. Or D, I will write a word on this paper and you copy it. What do you think? Cognition. Reasoning would be A. Reasoning's A. What does B tell us? This is giving attention to details. 100, you got to count by 7. So what is that? 93, 86. Like, okay, or yeah. All right, C, tell me how you were transported to the hospital. That one is a memory question for them. Okay. And D, writing down the word is a language and a skill. Copying skills. You want to read that one more time? You kind of want to know something about this one. So we talked about cognition. So they have to be able to explain with cognition. This one was what? Attention. Because they have to pay attention to this. This one is about, C was about memory. And this one, what did I do? Okay. It's about language and copying skills. All right, question 2. Nurse came for an older adult, usually alert and oriented, when the patient exhibits a change in mental status, for which most cause does the nurse initially assess? Mental status change, older person. First thing you think of. Okay, first one we want to think of is infection. A, infection. A lot of times they're not emptying their bladder. There's reasons like that, but a UTI, urinary tract infection, is one of the most number one causes for patients that's been alert and oriented and then they flip. Okay? We do want to be aware of sedatives. Has there been any medication changes? So, I mean, all of these are important, but we're saying the most common cause is infection. Oxygen insufficiency. Of course, we don't give enough blood to the brain. We're going to be confused. Okay? And electrolyte imbalance. Which one do you think of when you just did all your electrolytes? Which one mostly will send them in a state where they're not alert and oriented? Which electrolyte specifically can you think of? Sodium. Good deal. High or low? Oh, you didn't? You thought you were done with fluid and electrolytes? They thought they were done with fluid and electrolytes, but look, it's going to follow you all the way through. All right. Let's see here. Okay. Last question. The nurse is caring for a 30-year-old patient who experienced a frontal lobe infarction after a motorcycle accident. You don't usually see 80-year-olds on a motorcycle, right? That's what I was talking about, this risky stuff. What is the appropriate nursing intervention? Okay, we're thinking frontal lobe. What kind of things do we have to think about? What's going to be messed up for him, right? Are we going to put the bed alarm on? Are we going to put everything just in front of him? I mean, it was a frontal lobe infarction. Are we going to use... Thanks, I appreciated that. Are we going to use the picture board to assist with communication? Or are we going to instruct the patient to use the call light prior to getting out of bed? What do you think is our best answer on this one? I heard a C. That's not a bad idea, but it would not be the most appropriate for starters. Okay, because we can always use that as a form of communication. I heard A. Anybody else agree with A? You know? Yes. Safety is almost always number one. And the bed alarm. Oops. Maybe I'll learn the 2-tap system after all. Okay, we got to keep that bed alarm on because why would D not always work with a frontal lobe infarction? We give him his call light. Here, just press on this. Right, if it's a frontal lobe, he doesn't have his reasoning. He's not going to be able to understand. Okay, and it can be a parietal area is going to cause spatial issues, but just not all in front. That doesn't necessarily, you won't know that. Okay, and then communication-wise, our temporal lobe is the one that communicates for us. Okay. So the call light's a good thing, and we can do that, but it's not going to be the most important because that bed alarm is going to help us assess if he's going to fall, get out of bed, wander, if he's not on a monitor. A lot of these neuro patients will be wandering around. You'll catch them somewhere else, and you're very thankful if they still have an armband on and you know who they are. Or security calls you, that type of thing. Okay. Well, I have 1 minute left. What kind of questions do you have for me? All right. So give you time for questions. Was there anything you want me to back up and go through again? Hopefully. Okay, so what kind of posturing is this? Flex. Decorticate. And what's the other one? Which one's worse? De-Cerebrate. Okay. Anything else as you kind of go back through?
Enjoy lunch.
Enjoy your lunch, you bet. Thank you.